Good afternoon, everyone. Welcome to the Take Heart Special Informational Webinar. This is Addressing Challenges with Cardiac Rehabilitation Amid COVID-19 Pandemic. My name is Cynthia Klein. I'm the Project Director for the ARC Take Heart Initiative. Just really wanted to thank everybody for being here today. Please know that our thoughts are with you every day and that we hope everyone is staying safe and staying well during this time. Next slide. Great. As we begin, I'd like to introduce Dina Moss to make a few opening comments, and then I will provide a few updates on what to expect with the program in the coming months. So Dina Moss is from the Agency for Healthcare Quality and Research, and she is one of two project leads we have for this project. Dina, are you able to say a few comments?
Yes, can you hear me?
Yes.
Wonderful. So on behalf of the Agency for Healthcare Research and Quality, and Michael Harrison, our initiative co-lead, and myself, I want to welcome everyone to today's webinar. As I think everybody on this call knows, ARC is funding the Take Heart initiative to help hospitals increase participation of their eligible patients in cardiac rehab. But now, exactly 1 year into our planned 3-year project, we have hit our first unanticipated hurdle. However, our goal of supporting you, our Take Heart hospitals, remains unchanged. So in the recognition of the immense challenges you're facing, we are postponing our originally planned training sessions while working hard to try to support you in as many ways as possible that you might find helpful. We at ARC know from past field-based projects that we've supported that it can be both informative and reassuring to hear from one's peers about how they are facing shared challenges when they arise. So we're hoping that today's event can provide a forum for you to begin to share your experiences with each other, as well as an opportunity to gain some insights from leaders in the field. If we hear from you that you want more opportunities of this sort, we will certainly consider options for providing them. ARC has a great deal to learn from you, and we deeply appreciate your commitment to the well-being of your patients and your coworkers. And I want to thank you and recognize you all for that and for taking the time from that important work to be here today. On behalf of ARC, I also want to thank today's panelists for their time and insights in support of our initiative. And the way they so quickly rallied to help pull this together. So thank you all, and with that, Cynthia, I turn back to you.
All right, great. Thank you, Dina. So as many of you know, we have put a pause on a couple of Take Heart activities. The two key ones really are the training modules. We won't be doing those live for at least the next 2 months here. The second one is that the learning community that was to start this month, we're going to go ahead and put a pause on. We are going to resume those activities as soon as it makes best sense to do so, and we will stay in communication with you to make sure you have ample time to get started. So I want to appease any concerns that there might be there. As we get ready, let's go ahead and go to the next slide. All right, we wanted to make available too. We've included these as some hyperlinks on this slide and in the notes. There are some COVID-19 resources we thought you might want to be aware of. There are two from CDC. The first one is the main COVID-19 resource page that CDC has. The second is the COCA, or the Clinician Outreach and Community Activity page. If you didn't already know, there is a AACVPR fully dedicated COVID-19 page that has a number of really great resources on it. And then, as of this morning, we've updated the Take Heart website as well. And we have a Take Heart resource page that includes, it's the place you can look for. If you can't find an email from us, it'll update, what we're planning to do with the project. So there'll be project updates there, some things we're doing to support hospitals during this time, and then some additional resources towards the bottom of that page as well. So you can take a look for that page when you get a chance. Let's go to the next slide. So getting into today's session, really what we've planned for today's session, there's actually a picture of the resource page. So onto the next slide from there. What we've planned for today's session, is really an opportunity to, hear insights from experts and from your peers not so much on safety related to COVID-19. That could be, a session or two or more by itself, but really how we can all be supporting cardiac rehabilitation programs and their patients during the pandemic. What we've planned for this session as best as we can through WebEx is a interactive, moderated discussion. We have 3 panelists who will join us today. We'll use the chat functions, the polling functions, and really give you an opportunity to ask questions of our panelists through the chat function, but then also maybe share insights with your peers, with other hospitals, as well as Dina mentioned. All right, next slide. So during today's informational webinar, we'd really like to hear from you. So at the bottom of the screen, you'll see a conversation bubble that's similar to the one that's pictured here. Clicking on that bubble will open up a chat box. As it says here, if you can set the to all panelists, so that way everybody can see your question. This ensures that everybody can see and they can be part of that discussion. We do ask if you can keep your questions general in nature. So maybe not so much hospital specific, but maybe general in nature so that everybody on the line can benefit. And we will try to get to all of the questions today. We may not be able to get to all of them, but please know we'll follow up with any unanswered questions after today's event. One more logistics slide next. This is how the polling slide will look. You'll notice we have a couple of polls set up. On the right-hand side, you'll see a question, and you'll have the opportunity to click. When you click, the submit button will turn gray, and then we'll be able to show everybody the responses to those polling questions. And then one more slide. All right, so here's our first polling question. The question we have is to get a better sense of, the experiences of the hospitals that are participating today. What best describes the current status of your hospital's cardiac rehabilitation program. So you should see on the right-hand side 4 options, A through D, ranging from completely shut down to reasonably normal operations. If you could take a few seconds and respond. All right, Jean, how are we doing?
Okay, we currently have 50% of you finished.
Just give it another couple seconds, and then Jean, if you want to show the responses.
Sure. We have a bunch of people who just started theirs. We're now at 60%. A couple of people are still in progress.
So we've got this question, and we have one additional question, really to kind of do a quick survey of where we're at. And so this will tell us a little bit about where you're at. The next question is going to ask you a little bit more about what your interests are in today's session, your primary concerns.
Okay, I'm shutting down in 3, 2, 1.
Thanks.
And I will put up the results shortly.
Okay.
The mice are busy calculating. And on the right, you should see the results.
Yeah, so what we are seeing is that second option, which is somewhat what we expected, seems to be the primary. So to see the full one, it sounds like most are responding that, all patient visits are canceled, but you are still providing web and phone-based support to patients. Okay. And then we had one other question going to the next slide, Jean. And this question is really asking you to use that chat function. So again, you'll see the chat bubble down here at the bottom where Jean's indicated. If there are some topics that you are particularly interested in having us cover today, if you could go ahead and include them in the chat box. Again, a reminder to send them to all panelists. We'll be able to take a little bit of a look at that as we go through today's session. Okay. In the interest of time, let's go ahead and go to the next slide. We have 3 great panelists today. We are really lucky to have them. They're folks that we've been working with for a while. You may know some of them through past presentations. Today we have Dr. Steve Katayan. He is the Director of the Preventative Cardiology and Cardiac Rehabilitation Unit at Henry Ford Hospital in Detroit. We also have Greg Merritt, who is a cardiac rehab program graduate and founder and CEO of Patient is Partner, to represent the patient perspective. And many of you may know as well, we're really glad to have Kathleen Trainer with us. She is the Director of the Cardiovascular Disease Prevention Center at Massachusetts General Hospital. She's also the past president of AACVPR. And another voice you're going to hear here in a second that you'll hear an awful lot in the coming weeks and months is Steve Hines. He's a new addition to our team. And Steve is going to serve as our moderator today, and you'll hear him a lot in our training and technical assistance activities going forward. Steve?
Yeah, thanks very much, and good morning or afternoon, depending on your time zone. We're framing this in terms of a series of questions, and given the circumstances, a lot of questions aren't necessarily knowable, and so we're going to start off with one question where the answer may be a lot different, just depending where you are. So I'm going to pose this first question to Kate, and if we can just see the question there. We just want to know what should your hospital's cardiac rehab program be doing in response to COVID-19? So, Kate, why don't you give us some thoughts on this? All right, and Kate, I think that you're still on mute. You need to unmute yourself before you can talk.
Okay, I think I'm unmuted now. Sorry. Just wanted to thank everybody for joining us today and hope that certainly everybody listening in is feeling well, doing well, as well as your families and loved ones. So really there's no correct answer to this question. I think that it depends on a number of factors. One may be just where you're located. As you can see, if you look at the map of the country, there are some real hot spots currently. New York, Massachusetts, where I am, Detroit, where Steve is, and some of the West Coast cities and down in New Orleans. Very challenging times right now. So I think it's safe to say that your response will be dependent on kind of where your situation and where your hospital is. And what will be very important is that you continue to work hand in glove with your hospital leadership, your state and local governments, listening to what their guidance and recommendations and management plans are. If you are, there's a very small number of you, it looks like, from the polling that are still in operation. I think it's imperative that you be paying attention to the kinds of strategies that all of us have learned are so very important. And that is certainly to be screening your patients as they come in, screening your staff, and then being very attentive to, the hand hygiene, the equipment hygiene, all of the things that we know will be very important to protect each of us. I think that, we're going to share a lot of ideas today, and I think there'll be no one-size-fits-all. And what's most important is that you take away from this perhaps some new ideas or some new ways of thinking about how to approach this. And so that's really what our intent and our hope is today. So I think those would be my biggest and most important recommendations at this point.
All right, thanks very much. Some good insights. And let's turn to a second question, which is also difficult to answer given the circumstances. And I'll pose this to Stephen Katayan. Stephen, from your perspective, how long before things return to normal, whatever that is?
Hi, Steve. Thanks for having me join. I want to make sure you can hear me. Audio's okay?
All is good.
Okay. So, hi, everyone. And like Kate, I welcome everybody to this project and my best wishes as well. And obviously, the short and easy answer here is no one knows. I think it will vary depending upon where you're at in the country. Each of us will have a different surge point. I know here in Detroit, we're expecting the surge sometime over the next 7 to 21 days. So it will vary. But the two thoughts I'd like you to keep in mind, and we will discuss later during this session, is, or at least one point for sure, is we need to be thinking about now, how are we going to ramp up when there's so much pent-up demand when we're on the other side of each of our surges. So as we come out of, stay-at-home messages from our state governors and the hospitals say, let's start to re-engage in routine clinic visits, we need to be thinking about, how are we going to onboard and get started a really large pent-up demand. I'm hoping that for those of you that have telephone connects with many of your patients now, that you will be starting to talk to these patients, engaging these patients, so that when we do get to restart up, you'll know what you're looking at, what the volume is. So there'll be a new normal when we get going forward. We'll have a lot of options that we have to consider, but it will be a large demand, and I think we should prepare for that. So hours of operation may change, and how we deliver things may change.
All right, great. Thanks very much for those insights, Steve. And we wanted to make sure that we are keeping in sight the patient's challenges and needs in this pandemic, and some of those are the same and some are different. So let's turn this next question to Greg Merritt. And Greg, from your perspective as a CR program graduate, how has COVID-19 impacted what the CR patients are needing in this very unusual time?
Great, Steve. Thanks very much, and thanks everybody as well for participating in this. I think a lot about this from each phase that I would have been a patient, right? So I think a lot about the notion of what it would have been like right after my incident and leaving the hospital, what it's like if I'd have been halfway through my program, and what it'd be like as a maintenance patient now, and those in phase 3. And I think all three matter a lot in different sorts of ways, from if we're automatically referring us and we don't know where to refer to, that's a challenge to be clear about that. If we are in the program and think, uh-oh, I thought I was just doing this and now I'm supposed to do this on my own, creates both more fear and concern, and a sense of, again, all of this is not normal. And I worry specifically about, as all of you know, and I can speak as myself, the role of anxiety, depression, other things of thinking about this, and how do we manage the connectedness that needs to happen. So one of the best things, in my view, about place-based cardiac rehab is that not only do you get the expertise of the staff who's there to help you, that has all the knowledge, you are also with people who understand this perspective because they're going through it as well. And so I try to think about how might we, through this time, be certain that all three versions of what I've described, of patient just out of the hospital, patient in the program, patient just graduated, how do we figure out ways that might be able to connect to each other to provide the sort of social support that I think is so incredibly important during what I describe as this physical distancing time that shouldn't make us less social. We need to be physically distanced, but I certainly hope we don't become less social as a result of that.
All right, thanks very much, Greg. That's very useful insights and good reminders, because a lot of patients and a lot of people just in general are fearful, and that just makes some of the other challenges that they're facing even more challenging. Let's turn to a fourth question now, and let's turn this initially to Steve. But how can cardiac rehab programs stay engaged with and support their patients despite this reduced or eliminated physical contact, since that seems to be going on in a vast majority of the facilities represented on the call today? So Steve, what are your thoughts on this?
Thanks, Steve. My first point I'd like to emphasize to everyone is that you appreciate that we are smart people and we can solve complex problems. So I would first turn to yourselves, to use your situations to decide how best to navigate. Now, I'll also say that over the past 2 to 3 weeks, I've probably heard from 1.5 to 2 dozen different programs. And each time I've talked to these people, and we inquire of each other, how are you doing this or that? I've learned a lot of creative ideas. So let that stuff grow. So anything we might say here, you should consider. But also, bring your own firearms to the table, or so to speak, your own guns to the table to help solve these issues. Now, I will say that uniformly, and even here at Henry Ford, that we're talking to patients, at least new patients that we're onboarding that are post ACS or post Revasc. We're trying to talk to them initially 2 times per week, and then scale them down to 1 time per week as we feel comfortable if they get to that point. Current patients that were in the program when we had to shut things down, we're probably following 1 time per week. Some of this is doing video. We have the ability to do video conferencing, but a lot of it is a phone call as well if the patient's not able or doesn't want to go to video. So those are pretty simple to do. And there's a host of websites, and those were shown earlier on by Cynthia and Dina, that there's a whole host of websites that are available to help through AACVPR, ARC, and other organizations, and for the Take Heart website, on things that we can do at home. Again, even on the Henry Ford's website, there's patient education materials that you could pull off, and some other orientation videos we're putting up. Others are welcome to use. So look at your resources, pull those in. Use your EHR when you can to schedule appointments so that there's an actual scheduled time in there. Some EHRs will allow for texting for phone reminders when appointments might come up. And then, through email or through other exchanges, get informational material out, whether it's links to other organizations or question and answers that you've written that you want to push out. All of those are fair game. So this is a good time for creativity for solving, complex problems.
All right, Steve, thanks very much for those insights. And let me turn now to Kate. And you also had some thoughts on this. We're still on question 4. Preceding slide, please. Kate, why don't you share some of the things that you're considering at Partners?
Sure. So I'm going to just follow up on a couple of things that Steve brought up. And also from your early polling results, it looks like at least 50% of you have some reach out to patients with either web-based interaction or phone-based. And, letting the rest of the care team know what you're doing and what you're finding when you're talking to patients is so very important. So, the bullet point that talks about documentation is essential. I think that one thing to remember is that you might be the most frequent contact with that patient at home. There's not a lot of physicians right now that have time to be in touch weekly with their patients. So, you will really be the eyes and ears for them in many ways. So, really elegantly capturing what you're talking to patients with, what you're hearing, what they're doing, the progress they're making, the challenges they're facing are going to be very helpful to them. There was a great article in the New England Journal of Medicine written by a physician about the invisible hand during a pandemic, and that's really what we are. All of us are working remotely, or a number of us from what we can see here, but that doesn't change really the nature of how important it is that we keep in touch with patients and do the things that we've done when they're in your facilities, quickly touching base with how things are going, and then, paying attention to all of the aspects of the treatment plan that are so very important in touching and helping them to continue to make progress even in the face of this uncertainty. And by doing that and capturing that and sharing that, you're going to be showing your administration, your cardiology leadership, that you are productive, that doesn't necessarily require you to be in facility or face-to-face with patients, that you're flexible and you can be responsive. And those are all good qualities and important, I think, attributes that hospital leadership will find very, very useful and will be looking to you to be able to do at this point. Remembering that patients at home are very overwhelmed. Everybody's a little overwhelmed. This pandemic has touched all of us. Maybe the pathogen hasn't touched you personally, but the pandemic certainly has. And so in the face of that uncertainty, keeping other members of the team informed, I think, will be very useful in helping everybody to feel a little bit less anxious.
All right, thanks very much, Kate, for those insights. And we actually had a comment in the chat about the importance of capturing insights from the patient experience during this time. So Greg, why don't you react to that as well as to the comments of Stephen and Kate?
Yeah, I think I certainly agree that Stephen and Kate said. Again, from the patient side, as I think back to when I was in rehab, the most important piece is going to be these sort of regular contacts for all the reasons that Kate just described, in the sense that for many of these patients, it was overwhelming to have an incident. Now it's overwhelming to have this happening at the same time. Now I need to find people who actually I can trust and understand what's going on with me. And so I think that piece will be incredibly important to reinforce the kinds of things that all cardiac rehab programs do, from whether it's, how do I continue to do this if you're not going to monitor me in the same sort of way, and all the worries that come from that. And so managing what it means to do nutrition during a pandemic, and that would require more thinking about things like grocery shopping. What about me going to a grocery store because I have this incident, so I meet all the things I'm watching on the news about these conditions now that are going to be problematic. And so I think understanding what it means to have true caregivers by saying, I just didn't get left in this sort of system and not thought about, I think is really critical. And I'll just make one more point to go along with Stephen's point about, how much we can learn from each other. If you haven't already done so, I would really encourage you in your local facilities, if you're brainstorming ideas and thinking about things, invite a patient to, particularly might be a phase 3 maintenance patient who's gone through your program, my guess is they will have an equal amount of insight into what might work in this new model that you're trying to create, and some things that would be really particular to your program, because I'm doing that now with Michigan Medicine. We're gathering together to do some work on brainstorming what this new future looks like. And I think having a couple of patients on there, I think will make a big difference for everyone.
So Steve, this is Kate. I just wanted to jump back in and say one thing in listening to Greg, and that is, one of the things that we found, and this has actually been documented in other countries that have experienced this, is that patients are afraid to go to hospitals, and that seeking care has become a real challenge in the pandemic, that people are holding back, and there's a lot of concern that they're not being attentive to or paying attention to the kinds of other health issues that may either progress or develop during this time. So, again, it's one very useful way that cardiac rehab professionals, as you're reaching out and having these virtual contacts, can be attuned to those kinds of things, and really helping people to understand that, it is safe for them, if there is need for them to have care and seek care, that they will be well managed, they will be well taken care of, and there are safeguards to protect them.
Yeah, thanks very much for that. And certainly it is harder to keep the patient at the center of everything when the patients are just physically absent. So that's a very good insight to add. All right, let's turn to a fifth question now. And by all means, if you have reflections on things you want to share with your peers that are in the audience, use the chat function for that. Change who the recipients of the message are to the entire audience, and then you can share, or if you're interested in getting other audience members as well as panelists' reactions to things, just type your comments in the chat and we will follow up on them. So a fifth question now, and beyond the regular phone calls, Steve, you started to get into this a bit ago, but what are the other options for getting patients the information and the support that they need? And actually, we're back to Kate here for a couple of thoughts, and then we'll turn to Greg and then back to Steve.
So I think a couple of things. You have to quickly pivot. And so because you may be working remotely and not have as much contact with each other, one of the strategies that we have incorporated is a daily team conference call, so that we can keep in touch and share kind of what our experiences are in talking and touching base with patients over the course of the week, and also pulling in other team members that may be of some value. So for instance, the nutritionist, there may be somebody in the course of your touch point or conversation has had some nutrition questions and could really use a little extra support there. So that's an important concept not to lose, that, cardiac rehab is a team sport, and don't lose that in the midst of all of this, that working together is still really beneficial for patients. The other is to leverage your EMR. If you're using an electronic medical record, know that you can message patients very quickly. They can message back to you. You can also use that as a vehicle to send them updated resources or educational materials that you may think may be of some value to them. So I think that those are very helpful. We've turned to some conference calls for education. We have patients calling in twice a week. We offer the same topic 3 times throughout the day, and they're led by the staff, so they're familiar, voices to the participants on the call, and we're just following our regular educational curriculum with them. And also have sent things for patients that don't participate in the patient portal through the electronic record, have sent out materials through the snail mail, so that they can still benefit from some of those conversations and some of those educational materials.
Excellent. Greg, some additional thoughts from you?
Yeah, so I think I would just reinforce some things as Kate described, sort of the conference calls. It's not just a one-way street, right? So this is an opportunity, I think, not just to be heard on a conference call, but to figure out how do patients find each other. So I think, for example, there's an opportunity here, if you haven't thought about or don't do group orientation, giving that as an option and an opportunity for people. So much of us who have these incidents, one of the things we're looking for is who's like us. We're trying to find people who experience, try to make sense of this experience of having a heart attack, a cardiac event of some sort, with other people who are like us. And as much as you all as caregivers are wonderful about this, we're still trying to find each other to say, how do we learn from the person who's to the left or right of me here? And so I think opportunities to connect patients both to you, but also to each other where it's appropriate and where they would like to have something like that. And oftentimes we're just not asked, would you like to get to know other patients? And so I get all the privacy stuff, but I think if there's an opportunity for people to get to know each other, there's some real benefit in that social support that really comes from, what happened to me in my, place-based rehab is I made lots of connections, but mostly in the locker room. So how do we do that in a way that is a part of the process that gets us to think about how we can help each other patient to patient?
All right, excellent. And Stephen, you were talking a bit earlier about the videos from Henry Ford. So why don't you say a little bit more about those and how patients respond to them and why you put them together?
Well, sure. Thanks, Steve. Just quickly, I'm probably the least best qualified to talk about going online and finding resources. But having said that, I've learned just watching our staff operate, there are a host of online opportunities for everyone to access. You may have to vet some of them from different professional organizations to use. But as I mentioned earlier, we received a lot of calls about how we run our home-based cardiac rehab program. And to supplement that program, we produced, as you can see on that one slide, I think it's 20 or 25 or so 3 to 10-minute audio PDFs, which you are all welcome to use. They're fairly well done, still pretty contemporary. If you search around those pages, we're going to load up today a fairly well done 5-minute orientation video that talks to patients and from providers to new patients coming into cardiac rehab. We're going to load that onto the website for our patients. We do that. We use it now in our brick and mortar orientation, but we're going to load it up on the website. That'll be up soon. So point being, there's a lot of resources. This is where I mentioned earlier, be creative, really start to think about how we can do this, vet the things that you want to do. They won't be perfect, but give the patients resources, and it's a nice challenge and kind of growth step for the staff as well.
All right, thanks very much. And those are great resources. And as Stevens mentioned, there are others on the web as well that have been developed and are really going to be a valuable resource to point people to in a time when they can't come into your facilities. Now we're going to turn away from our panelists who've been doing a great job and turn to the audience. And what we'd like you to do now, before you start typing anything in, if you can change who this message is to so that it's being sent to everyone, because we'd like you to be able to see the comments that your peers are making. And if you could just take a couple of minutes, you've heard about some resources, but there may be some other things that you're doing or some things that you're doing that you find are working really great. That we'd like to see from you what you're doing in your facilities to support your patients. So if you can use the chat function and share with us the strategies or the resources that you're using to successfully, or as successfully as you can, maintain and develop virtual connections to your cardiac rehab patients. So chat function's a little bit intimidating, but go ahead and type in your thoughts, and we'll get the panelists to respond to them. And if you see an idea from somebody else, we will get, you can respond to that as well. All right, are things coming into the chat function?
Nothing yet. Oh, here we go. We have some questions, but not comments directly to strategies and resources that people are using yet.
All right, well, I'm not seeing the questions, so why don't you, if any of the questions are ones that we'd like the panelists to respond to, why don't you read those off, and we'll put the panelists on the spot and give them a chance to respond to a couple of those.
So this is Kate. I actually see some things that might be worth sort of talking about. And one was, are we fearful about the impact of programs going to full home-based rehab during this time and setting a precedent? And then further down, Dr. Sperling from A Million Hearts has talked a lot about, or is suggesting that, this is the time for us to be looking at these alternative delivery models and really getting a good sense of, in terms of data gathering, what the patient's experience is, what the differences that it makes for them, what their perspective is, as Greg would think would be so very important, and capturing that. So I think that we're going to learn a lot from this, right? And I think this is our opportunity to really inform our practice. I suspect that cardiac rehab will be different after this, but we're going to have perhaps a better vision and glimpse at which patients do well using some of these strategies, which patients still perhaps need more of the center-based, face-to-face, in-person interaction. And the data that I hope you're all capturing is going to be what helps inform some of those decisions. So this is where we're going to make lemonade out of lemons, and I think that we all need to be very forward-thinking, not only in the immediate term as to how we connect and keep patients making progress and ease their anxieties and fears, but how do we get better at what we do? And this is really an opportunity for us, and that's the way that I'd like to frame this. And I think, data will always drive good decisions. And so I think that comment by Dr. Sperling is particularly important for all of us to be capturing and trying to understand the difference that we're making and what's working well, and where do the challenges lie.
All right, thanks very much. And some things are trickling into the chat, and I realize that it's not a platform or a functionality that you may be real comfortable with, but go ahead, give it a try. It'll give you a chance to tell your kids what you did today when you're struggling in that as I think many of us are. But one of the questions that came into the chat, which was one that we certainly are aware is an important one for many of you, is whether the video or phone calls to support patients are able to be billed for. And Hillary Wall from CDC is tracking this issue very closely. And Hillary, if you're able to, we'd welcome you to comment on this issue because we know that it's an important one. And if you'll remember to unmute yourself on the screen as well as on your phone.
There we go. Hi, everybody. Hillary Wall, I'm the science lead for Million Hearts, and I'm so glad so many of you were on the call today. I just want to, talk to you a little bit. As you all know, during the COVID-19 pandemic, CMS has temporarily allowed for reimbursement of telehealth visits for a number of clinical services. And it's really come to the attention of Million Hearts and others that of the 190 codes that CMS initially approved for telehealth visits, unfortunately, cardiac rehabilitation and pulmonary rehabilitation codes were not included. And so we have been working with CMS to have them consider reimbursing for telehealth visits for cardiac rehab and pulmonary rehab. And I'm quite hopeful. I don't think this was necessarily done intentionally, so I'm hopeful that we'll see some progress in this space, and we will be sure to keep this group updated if and when progress is made.
All right, great. Thanks very much. And there have been a couple questions on very similar lines related to billing and as Hillary said, it's an issue that's actively discussed within the government. Let me and thanks for some additional comments there using some of the smartphone technologies to track what people are doing. If you're able to do that, that's an interesting cutting edge thing. And as a couple of the panelists have mentioned, in a challenging time, sometimes new ideas surface that prove to be valuable for an extended period. So thanks for those comments. Let's go ahead and turn to the next question to our panelists. We've given them a brief break, but let's turn now to a sixth question, which is, how are you handling or preparing to handle the onboarding of new CR patients, ones that haven't started their cardiac rehab? So let's turn first back to Kate, and why don't you share with us what you're doing at Partners?
Thanks, Steve. So you can never communicate too much. And by that, I mean we are still in touch with our cardiology staff, and this is where your cardiac rehab champion that you've identified can be so very useful. It's important to let that cardiology team understand and know that you're still in business, that you're still operating and you're still reaching out to patients and you're still welcoming and wanting referrals, because you don't want that pipeline to dry up. So that's probably, one of the very first steps was that we didn't want anybody to think that we were going to lose any momentum with getting patients into programs and reaching out to them. So as soon as we get those referrals, or for all of the patients that were in the queue that we hadn't yet had an opportunity to evaluate or to onboard or orient, whatever your words are that you use prior to patient beginning the program, we've reached out to all of them. And we continue to reach out to all new referrals to invite them to participate in these weekly educational calls that we have. We also let them know that the team is available to begin an outreach to them on a regular basis, as we are with our currently matriculated participants. So, we let them drive the bus, and we meet them wherever they are and offer them the same opportunities that we've afforded the folks that are in the program. We've also used, so our cardiology leadership has daily touch points in the morning, and so I've worked through the medical director to be certain that all other division chiefs or section chiefs within cardiology are aware that we're still in business. So, continue to market your services, make sure that the word is out that you still are operational. And as I said, and you definitely need an outreach to those other folks, because they're the ones perhaps that need you the most, because they've had actually no intervention, no touch point from anybody, no opportunity to appreciate the difference that cardiac rehabilitation can make. So extending yourself to them, I think will pay you back and pay them and be very beneficial for them.
Stephen, we'll turn it over to you to get your perspective from Henry Ford in the Detroit area.
Thanks, Steve. A couple of things I just want to go backwards on first before really addressing your point, just from comments that are made so far. In terms of the phone calls that we're making, please understand whether it's CMS reimbursed or not CMS reimbursed. This is an important thing that we do. This is the patient care, and CMS, I believe, has suspended our requirements to have our ITP signed every 30 days. But it doesn't obviate us from having to make sure we touch base with patients about their care plans, their education, their medication compliance. The second point I wanted to back up and mention is that, and Kate mentioned this, it is really important that we track our volumes that we're doing with these phone calls, whether it's video or asynchronous phone, because it will demonstrate activity to divisional leaders when should that information come about. Relative to going forward and onboarding new patients, first one is, and if this has been the perceptions I've heard from staff, is that patients are very appreciative of us touching base with them, not only our current patients, but the new ones that we're starting to onboard that maybe were in an orientation that we had to cancel and go to phone, patients that just had an ACS event that we're now touching base for the first time. These patients are appreciative, and I would ask, as we onboard these patients and talk to them about whether Joe or Mike or Sally is going to follow up with them next week, and we can even set up that first visit with them later in the week with Mike or Joe or Sally, that they're going to hook up with them and start to get them started on their cardiac rehabilitation path. And again, it's patient education, it's medication compliance, it's exercise supervision, or at least exercise discussion. So we can do all these things we were doing before, where our metrics are still the same, our objectives are still the same. We're carrying out cardiac rehabilitation just in a very different model. So we still want to cover the major topics that we want to cover. We still want to deliver the service. We certainly have some handicaps. They're not right with us. The amount of exercise, the intensity of their exercise might or might not be back down some, but we still want to progressively improve their function while at home, return to normal daily activities. So onboard these patients, look down the road. How are you going to handle this volume? Spread it across your staff. These phone calls might only be 10, 12 minutes, but it's enough. And then, as Kate mentioned earlier, we want to document this. This could just be a smart phrase in the EMR under notes that you had a phone call with patient and they did a touch base for cardiac rehab.
Very much. And I'm just skimming also the things that are coming in the chat and feel somewhat sheepish about expecting to see really thoughtful, extended answers like some of you are sharing now in 15 seconds after we posted the question. So thanks. Keep those comments coming in because I think that they're very useful, and some of them are really consistent with some of the comments that the panelists have been making. Let's turn now to
Steve, just a quick comment. I'm looking at one of the questions, and it looked like it came in from Jim, and it had to do with a template. We did build a template. You should do the same on what you want to get covered during these phone calls. It helps guide the discussion. It could be nutrition, it could be exercise, it could be weight management, it could be medications, anything that you want to touch base for. Have some blanks that people can fill in. It could be built right into the EMR. A template's a very good way to do it.
And I think, Steve, to follow up on that, that's a great point. It helps both to organize the staff as they make these calls. And, but I also think, what will guide you is the treatment plan. That, what's in those ITPs is really what is important. And it will, and Carrie Stewart, has just chimed in and said, the outcomes still matter, and we need to be paying attention to, are we moving people along in their self-management and their risk factor management and getting them to achieve the outcomes that we know to make a difference and to be important. I think that all of the strategies, you guys are coming up with some terrific strategies. I mean, I'm loving the creativity. So sharing among us is really what will be the most fruitful and will yield, the most number of options. But cardiac rehab has always been a high-touch, low-tech effort. And so don't forget that your touching of these patients is really what makes the difference. And that even though there are a number of software systems out there or some mechanisms to be communicating, there's still an element of human touch that remains very important. And as everybody has already said, or you've heard it a few times, the patients are so appreciative of these calls. They're feeling isolated. The social distancing has been challenging, and it's just really nice for them to have a warm voice and maybe a very familiar voice, one of the team members that they've worked with, calling in to check on them individually. So, bravo for all that you've accomplished so far. And but let's not lose sight of what cardiac rehabilitation is all about, and that should be driving these conversations and these interactions, because we definitely want to have data to show that patients can still achieve some important advances despite the challenges that we're up against.
Thanks. And it looked great. Did you want to make a quick comment as well?
I did. So part of it is just, I love the notion of templates. I think all of the things that are being said is exactly right from a patient perspective. The other place that I would, again, reinforce you doing is, as you build that template, invite a patient who's a maintenance patient who's been through your program, who you love, who you think is fantastic, to take a look at it with you, to talk about why this is an important piece, what it was for them that mattered. I think the more you can engage your patients who have graduated from your programs to get help for you, the more likely that will be a new way to look at something, a fresh perspective. So I just encourage you all to find patients who have graduated from programs and have them be invited back.
All right, thanks very much. That's an excellent reminder. I want to turn to the last question for our panelists. This hour is flying by, but we don't want to lose the fact that there are going to be some important decisions to be made and important strategizing to be done related to when to return to more normal. So as the pandemic eases, the question is, what should you be thinking about already so that you can be doing so that you're prepared to resume operations? And, Steve has pointed out that at Henry Ford, they're using some staff time now to review and update their learning materials and their policy and procedure manuals, and that's a good suggestion. And I think that, Kate, you had some ideas as well for this.
Yeah, so a couple of things. I mean, you might want to think short-term and long-term. So short-term is kind of the immediate situation that you're in, and capturing the data so that you can demonstrate your productivity and all. So, obviously how many touch points you've had, calls, tracking educational sessions, whatever number of new patients, contacted or brought in, as these weeks as we go forward. That's all important information. Tracking patient data, I think, is equally important. And, many patients have blood pressure cuffs at home, have scales, have glucometers. I mean, there's lots of ways that you can gather data from them about them. The software platforms that are available will help you if you're able to take advantage of some of those things. And then you want to think long-term, I think, a little bit. And I mean, we've sort of alluded to this and touched on it a little bit, but long-term in terms of resumption. And number one, the true resumption of opening the doors and getting patients back in and on those treadmills and bikes and all. So thinking about how you'll do that and be able to ramp up relatively quickly. But also, what have you learned in this process? And what have we all, we've all had to react and respond and work very differently. And yet, we will be effective. And so there are elements of what you're doing right now that you may want to incorporate that you hadn't had prior to the pandemic. And so think long-term about how some of these remote reaches can continue and endure beyond when we do get our doors open again, which we will. But I think that, as I said, cardiac rehab will not quite be the same after this, but I think that's a good thing. And I think that we're going to learn some great lessons, and the data is going to help drive that.
Thanks. And Greg, you had a couple thoughts here.
Yeah, just so part of me, I think those are great points that Kate raises. I also think this is, the making lemonade question is really an important one. And from where I sit, I think having opportunities to do, like A/B testing. So these aren't real experiments, but they're ways to say, let's try this with this group and let's try this with this group. And obviously the same standards. So we're not changing standards, but you're allowing yourself to really experiment a little. And I'll give you just one example. So if you haven't already done this, I'm curious about what would happen if you actually did video calls where in one group you called individually, and in the other group you had at least two people on the call at the same time who could actually see each other, could talk with them about. So you begin to get these questions and say, wow, it turns out that those people who did it in pairs, they actually went along and carried on longer than those who went with individuals. I have no idea whether that will happen, but I think the opportunities now allow you to think in ways that are really, so what I've noticed when I've tried to talk with programs about changes, the most challenging thing I've seen is there is simply no time, the inertia of every day continuing on as it always is. This at least has an opportunity, as this goes a little longer, to say, how are we going to spend our times really experimenting and thinking together about what could be different in the future?
All right, thanks very much. Excellent ideas, Greg. And let's turn now to, we're running a bit short on time, and the comments that are coming in now to the chat are lovely, and we really appreciate them. We want to reinforce that, if your question isn't answered, we'll address those after the event and post those things online. If you'd like to take a few minutes to comment to these last questions, if there's a piece of advice that you'd share with others based on your experiences, because different hospitals in different regions are experiencing COVID differently so far, just type in that piece of advice to the entire audience. And then if there are other resources or kinds of assistance that would be useful for you, tell us what those things are. And I know that CDC and ARC are very interested in understanding how we can be supporting the needs of the hospitals and the cardiac rehab programs as effectively as possible. So go ahead, you can start typing in any thoughts that you have there. But I want to turn now to just get some reactions to what you've been hearing. We'll start with Michael Harrison from ARC, and then we'll go to Hillary Wall from CDC. So Michael, if you can unmute yourself and then give us any thoughts that you've heard or that you have based on an action-packed 50 minutes.
Yeah, thanks so much, Steve, and on behalf of Bina and myself and everybody at the Agency for Healthcare Research and Quality, I just really want to thank all the folks who got on the phone. This has been an amazing hour. I'm sitting here taking notes. Thanks to our CDC people, colleagues who helped us get this organized really in record time. I really appreciate this, and I really appreciate the work that the app team has done to make this possible. And I'm really thankful to all of you who are on the call for sharing your thoughts, the polls, the chats, and I really appreciate, and all of us appreciate your being there for the taking care of the patients during this really amazingly challenging period. That is in some ways the most fundamental thing. We're going to do what we can at ARC. to continue supporting you. We're going to have to weigh the input that we've received from here, but we recognize we can't do much compared to what you're doing every day. So thanks again to all of you for your engagement, for your participation. Let us know what you think we can help with, and we will do our level best to try to do that. Steve, back to you.
All right, Michael, thanks very much. And Hillary, your thoughts?
Thanks so much, Steve. And, on behalf of me, Dr. Larry Sperling, our executive director, and all of the Million Heart staff, I want to reiterate Michael's thanks to everyone, our panelists, and all of you hospitals who are just so passionate about the work that you do in secondary prevention, that you're on this call during a pandemic trying to figure out how to continue delivering services to patients. It's just truly, truly admirable. And I thank you all. And I think, I've been culling through the chat that you all have been posting, and I'm sure that the whole Take Heart team is going to do that. I think there's lots of good lessons learned here. There's probably tools that can be shared. So we're going to be, digesting this and trying to get you the support that you need as soon as possible. And as I said earlier, anything that we hear about telehealth reimbursement from CMS, we'll try to get that information to you as well. And just know that there's a team of national experts from a number of organizations who are working with AHRQ and CDC to support you on these efforts moving forward during this trying time. So thank you all again.
All right, thanks very much, Hillary and Michael, for your thoughts and your commitment to helping the hospitals. And I'll turn it back over to Cynthia Klein now for the wrap-up.
All right, thank you, Steve. And a big thank you to everybody who's joined us today, both on the phone and our presenters. As everybody has said, this has been a wonderful exchange of information and ideas, and I think it'll be a rich resource for going forward as well. Just a couple of announcements right here at the end. So we will make the materials available from today's presentation on our COVID website page under Take Heart. We will follow up also with an FAQ document to make sure that we are capturing all the information that's been in the chat boxes. I want to thank you again so much for everything you're doing every day. As you close out of this webinar, you'll notice that there are a couple pop-up feedback questions. We do ask that you take a minute to go ahead and respond to those so we know what worked well and where we can improve. Hope everybody has a great afternoon, and thank you again. Take care.